Okay, welcome everyone. Today is our third webinar, which will continue a series of meetings every Thursday on current topics in functional neurosurgery. But two stops will be made along the way. The first stop is the next week. There will be the Functional Week, sponsored by the Brazilian Neurosurgery Society, coordinated by Dr. Luis Borba, Alexandre Francisco, and our president, Dr. Antonio Almeida. The next stop will be in the first week of August. There will be the Neuromodulation Week, sponsored by Brazilian Neuromodulation Society, coordinated by Dr. Daniel Benzecri. Well, to open our webinar, I present the president of Brazilian Society of Functional Neurosurgery, Professor Antonio Almeida. Antonio?
Okay, on behalf of the Brazilian Society of Functional and Stereotaxic Neurosurgery, I'd like to welcome everybody in our series of webinars. It's in a functional specialty. And I'd like to go back to Paulo to present Dr. Ludvic Zrinzo to talk today's psychosurgery.
Well, very well. Before starting our webinar, let's all agree how to ask questions and comments today. All questions and comments will be made after presentation of Professor Ludvic Zrinzo and the comments of the mediators, Professor Osvaldo Vilela and Professor Fábio Godinho. Questions and comments can be sent by clicking the Q&A icon. Don't forget. Everything explained. Let's start now. Today's topic is the impressive prevalence rate of mental illness disorder in the world explains why they receive significant attention from the medical science. Combining the patient with the best treatment and avoiding ineffective or harmful therapies are the goals of selecting the best treatment for patients in all stages of mental disorders. Neurosurgical precision is an important part of the treatment of the most disabled patients with various forms of aggressive mental illness. Today, we are going to discuss current updates. We have selected an important group formed by professors and heads of medical residence programs. Our moderators, Professor Fábio Godinho, is a head in functional neurosurgery of Hospital Santa Marcelina, São Paulo, researcher in biomedical engineer in the Federal University of ABC, São Paulo, Brazil. Professor Osvaldo Vilela Filho is a professor and chairman, Division of Neurosurgery of the University Federal of Goiás. Our speaker, Professor Ludvic Zrinzo, is head of the University College of London, Queen Square Institute of Neurology, Functional Neurosurgery Unit, London, UK. With more than 300 publications and almost 10,000 citations in papers and books, I present the most brilliant and recognized Maltese functional neurosurgeon in the world. Dr. Zrinzo, the stage is yours.
Hello, what can I say? That's a very flattering introduction. And I'd like to thank you and all the other organizers for inviting me to this webinar. I've had the opportunity to visit Brazil twice before, and I'm really sorry that I can't be there in person. But it's an absolute pleasure to be with you and so many other functional neurosurgeons for the next hour or so. So what I'm going to do is I'm going to start my slides so that we can have a talk about the chosen topic tonight. And I hope now that you can see my title slide, and I've been asked to talk about deep brain stimulation versus ablative or lesional surgery in mental health. How I'm going to put this into half an hour is beyond me. So I'm going to ask for your forgiveness if I skim over some topics and go into more detail in others. But I think if we start with the size of the problem, we've already heard about this from Paulo. If we look at this publication, looking at the global burden of disease, which was published in 2010, most of our work as functional neurosurgeons is with patients with Parkinson's disease, if you're doing deep brain stimulation and lesioning. This is the burden of disease of Parkinson's disease. You can see how minor that is compared to the burden of disease from depression or the burden of disease of anxiety disorders, which includes OCD. So we know that we're almost already all overrun by managing patients with Parkinson's disease. These patients really need our help as well. So we need to know whether we can help them. And the history of functional neurosurgery really goes back a long time, starting here at Queen Square, from where I'm sitting, with Victor Horsley, who was extirpating large areas of the motor cortex to help patients with dystonia in the 1890s. And these were desperate times with drastic measures. And the field has moved on. No one would ever extirpate the motor cortex to treat a movement disorder now. And the same is true for mental disorders. And here we see Walter Freeman doing an ice pick lobotomy for a mental disorder. And you can see the frontal leucotomies that were performed. And again, these were desperate times when we didn't have treatments for mental disorders. We didn't have medication for mental disorders. And these doctors were doing what they could in their best, in what they thought was in their patient's best interests, even though now we know that perhaps they weren't always giving patients what the best type of treatment. But I think the field has been overshadowed by frontal leucotomies, and therefore returning to surgery for psychiatric illness really withstands a challenge. And we've got to be very careful about how we reintroduce these therapies if we're not going to lose the opportunity to help very disabled patients. So ethics is extremely important. I think it's also important to remember that stereotactic surgery is a technique that forms the basis of what we do as functional neurosurgeons. And from the very beginning, when the stereotactic frame developed by Horsley was introduced to medical practice by Spiegel and Weisses, the neurologist and neurosurgeon, in their very first paper from Science in 1947, they said this apparatus is being used for psychosurgery. In fact, that was the first indication they mentioned, and movement disorders came second. So this has always been at the forefront of our minds as a discipline of functional neurosurgeons. So in the very beginning, we were creating lesions, and radiofrequency ablation was used to disrupt abnormal networks. And radiofrequency remains the gold standard of stereotactic lesioning procedures because we have the most experience with it. And we know that we can use a 500,000 hertz or thereabouts to heat tissues. We can create a predictable lesion by altering the temperature and the time, and by altering the diameter and the size of the probe. But there are other lesion techniques, such as cryotherapy that was used by Irving Cooper, chemical ablation, glycerol like Ohio used in Japan, laser ablation, a more modern version of this. And these, I won't say non-invasive because we are ablating the brain, but incisionless ablation used like gamma knife or more recently focused ultrasound. So stereotactic lesioning, there's a vast number of ways that we can do this. And we still use it for movement disorders. So some of you may have seen this video, but this is a lady from Malta, where I'm from, who has a brainstem cavernoma that's unresectable. And her main problem was that she wanted to hold her grandchild. But the very bad Holmes tremor you can see here, which is a mixture of intention tremor and ataxia, makes it almost impossible for her to get the pen to the paper to draw a spiral. We have to guide her. And because we're operating on one side of the brain, I elected to do a stereotactic thalamotomy because we know that lesions on one side of the brain don't cause risks as do bilateral lesions in motor areas. And we can see that immediately, this is even prior to the thalamotomy, just by introducing the probe, we have an excellent response to tremor, much better movements, and greater control, such that we have her writing before, which was totally illegible, becoming very legible afterwards. And she sent me a beautiful postcard of her holding her grandchild 3 months later. So this is just to demonstrate that lesions can have a positive function on the brain without causing deleterious functions. So she has not lost movement in her hand. We have simply eliminated the pathological process. And this is can also be true of mental disorders. Now, we all know that there's a very strong evidence base for efficacy and cost efficacy of neurosurgery and movement disorders, with randomized controlled trials for Parkinson's disease, tremor, dystonia. And the field in movement disorders has moved from ablation to deep brain stimulation. And the question remains, should we do deep brain stimulation or stereotactic ablation when treating movement disorders? And the answer is, it really depends. And my preference actually for unilateral procedures are lesions, because if you have a well-placed lesion, then you don't commit the patient to long-term follow-up in terms of battery replacement and maintenance and programming, and you don't cause a larger risk of problems such as swallowing problems or risk of side effects with speech problems, balance problems, gait problems. And we mustn't forget that this is why deep brain stimulation was introduced to clinical practice, because when we were doing bilateral lesions, the risks of these symptoms were quite high. However, recently, even though lesional surgery fell out of fashion for a while, there's been a resurgence in interest in ablation with the introduction of focused ultrasound. And again, we doctors are rather subject to fashion, and we like the sexiest, latest technology. But if you like a lesion with focused ultrasound, there's no reason not to like a lesion with the gold standard, which is radiofrequency ablation. So again, moving now to the main topic of contention, we know that these circuits between the cortex, the basal ganglia, and the thalamus really subserve different functions, including movement, including thought and cognition, as well as emotions. And if pathophysiology in these circuits can be treated by lesional surgery or ablative surgery for motor disorders, then the same may be true for disorders of emotions and disorders of cognition and thought. And therefore, this principle suggests that we may be able to help patients with stereotactic surgery for diseases such as Tourette's, OCD, anorexia, and depression. And in fact, from the very first publications in 1999 with deep brain stimulation for Tourette's, as well as deep brain stimulation for OCD from mainland Europe, there has been a resurged interest in deep brain stimulation or in surgery for psychiatry, and this has been driven by deep brain stimulation in neurology. And not only have we had case reports and case series, we've even had randomized controlled trials. So from our own center, this is a randomized controlled trial of deep brain stimulation for Tourette's, severe refractory Tourette's syndrome. This is a randomized controlled trial from Brazil of capsulotomy, a very elegant study showing a significant improvement after a gamma knife compared to sham gamma knife in OCD. We also have STN DBS for OCD, as well as ventral capsule or stria terminalis DBS for OCD. So the field is moving, but it's moving slowly. The number of patients that have been operated on has been relatively small compared to Parkinson's disease, and this despite the massive burden that we have in terms of mental health versus Parkinson's disease. So I just want to share you a few slides of what has been achieved. So Bart Natam and Van der Velde started in 1999, Van der Velde and Tourette's syndrome. And what we have here is a patient with Tourette's, and I'll show you his video.
Just generally sort of sitting here.
So you can see the tics, both vocal and motor. And these occupy every waking movement, causing severe pain and irritation. And after bilateral anteromedial palatal DBS, I'll let him talk for himself.
And after you adjusted the left-hand side, I think it was, I had a horrible sort of panicky sort of fight or flight adrenaline feeling for a couple of weeks. And as that started to fade off, the tics went with it, and since then I've actually been getting calmer and calmer. This is the calmest I've been in my memory, basically. First and foremost, I've actually been able to hold my daughter. That's been nice. I've been able to sleep in the same bed as my wife without actually having to sleep on the sofa every night. I'm not hurting myself every day. I can finish a sentence without swearing or whistling. That's always nice.
So we now have class 1 evidence from a randomized controlled trial that that DBS can help psychiatric disease and neuropsychiatric disease, such as Tourette, which is the border between movement disorder and a psychiatric disorder, mental disorder. And we know that when the battery runs flat and the patient doesn't know about it, these tics can reappear with a vengeance. So there's pretty good evidence for Tourette's. OCD is a huge problem. It's one of the highest global burdens of psychiatric disability worldwide. We know that these thought obsessions create increasing anxiety, and the patient performs a motor compulsion to try and reduce that anxiety, which it does do temporarily, only for the obsessive thoughts to increase that anxiety again. And you have this circuit which keeps fueling itself. Patients normally have complete insight into this, and cognitive behavioral therapy and SSRIs can be very effective, but 10% of these patients remain severely impaired. And over the years, we've had increasing evidence supporting deep brain stimulation and OCD, and I've already mentioned the STN-DBS trial from France. There's also trials from Holland and from Belgium showing excellent responses in a randomized controlled fashion. However, it's very important that for all surgery, just like Parkinson's disease surgery, patient selection is very, very important. We have increasing evidence, as I said, but it's also important to say that DBS is not a cure. And we know that actually what DBS often does is allow CBT and SSRIs that may not have worked before to become more effective afterwards. Nevertheless, long-term data shows that these patients who are extremely refractory, about a half to 2/3 of patients can have significant improvement with a sustained response. So in these very, very severely affected patients, that's actually quite remarkable. So a few years ago, the question in the field, we thought the biggest question was, which is the better target? Is it the ventral capsule or the anteromedial STN for OCD? So we had a very small amount of money and we did a very small trial, but we had 6 patients with the patients acting as their own control and patients being blinded as to whether they had anteromedial STN or ventral capsule activated. And after a period of 3 months, we would measure the effect and then switch to the other condition and then switch to both being on at the same time. And in this publication, what we found was if we looked at OCD symptoms in terms of measuring on the Y-box scale, we found that whether we activated the anteromedial STN or ventral capsule, there was a significant improvement in the Y-box scale. And there was no significant difference in the size of the response. What was really interesting is that if you activated both, there was a marginal improvement, but if you gave CBT after a year, there was a significant further benefit. Interestingly, when we activated the ventral capsule and measured the MADRS score, which is a score of depression, there was a significant improvement in the mood, which was not seen with the subthalamic nucleus DBS. On the other hand, when we looked at cognitive flexibility, the ability to change one's mind when you're presented with different evidence, there was patients with OCD tend to have cognitive inflexibility. They won't change their mind. They persist despite, right, the gas oven, it's clearly off, but you go away and you don't change your mind that the gas oven might be on. And what we saw there is that the ventral capsule did not improve that cognitive inflexibility, but the subthalamic nucleus did. So here we have 2 different parts on the same OCD circuit, but one node subserves cognitive flexibility, and the other node, the ventral capsule, subserves mood. So in this very small study of 6 patients, we're already beginning to dissect the circuits that subserve different higher functions within the brain, which I think is very elegant. Very importantly, when we look at global assessment of function, and that is how these patients actually improve in terms of their livelihood, everyday life, we found that at baseline, these patients were very severely affected with serious impairment and inability to function. And after a year post-CBT, these patients were really in the no symptoms or mild symptom range. So this really is quite significant. It's life-changing for these patients. The other thing that you don't read in papers is that this is very rewarding, but it's extremely labor intensive. These patients are very high maintenance. They require a lot of attention. They think that because the DBS improves their OCD, it can improve absolutely everything else in their life. And they have been really detached from society for decades, and adjusting to a normal life is actually very difficult. So there's a lot of work left to be done in these patients. One of the things we wanted to ask ourselves is, well, listen, ventral capsule is being used for deep brain stimulation, but it's also used as a target for capsulotomy. Why don't we look through the literature and see which papers have 1-year outcome, good 1-year outcome with Y-box scores, and let's look at these patients and see whether the patients tend to do better with capsulotomy or whether they tend to do better with capsule DBS. Now, this isn't a randomized controlled trial. These are patients gleaned from the literature. And a few years ago, we collected all these patients, and there were 108 patients that fit the inclusion criteria from capsulotomy and 62 that fit the inclusion criteria from capsular DBS. And when we compared the baseline, we found that actually DBS patients started off from a more severe point of view because they had had duration longer than capsulotomy, and that their Y-box was more severe as well. So when we looked at the overall, the first thing we have to say is that if your Y-box decreases more than 35%, you're considered a responder. But if your Y-box is actually less than 8 at the end of your treatment, then actually you're considered as if you're in remission. So we looked at whether there was a difference between being a non-responder or a responder between capsulotomy and DBS, and there was no statistical significance. However, if you look at remission rates, you are much more likely to be in remission if you had a capsulotomy than if you had DBS. So here's the first inkling that maybe capsulotomy may be just as good as DBS, but maybe slightly better. However, this is not comparing similar types of patients. So what we did is we stratified patients, and we looked at patients according to their baseline Y-box. There were no DBS patients with moderate OCD, so we can ignore that. But if you look at patients with severe OCD, you were significantly more likely to respond if you had a capsulotomy, and you were still significantly more likely to be in remission if you had a capsulotomy. If we look at the extreme OCD with a Y-box of more than 32, there was no difference between the likelihood of your being a responder if you had DBS or ablation, but you were much more likely to be in remission if you had ablation. So here what we have is a suggestion, again, it's not a randomized controlled trial, but it's a suggestion that capsulotomy may not only be as good as DBS, but may actually be better, a cheaper operation. Of course, side effects are very important. And if your side effect profile is weighted against DBS or against capsulotomy, that may be a very good decision to do one or the other. And what we found is that if you don't want to put on weight, you really should have deep brain stimulation because you're significantly more likely to put on weight if you've had a capsulotomy. But this isn't always a bad thing. Some patients with OCD are actually almost cachectic because they have obsessions that are about food. So weight gain is not always a negative. The important thing is that we have 5% of patients with DBS have equipment breakage and need another operation, and 5% have wound infection and need another operation. So you've got a 10% chance of needing further surgery if you've had DBS, and that's not relevant if you've had capsulotomy. So maybe, again, from the side effect profile, you may be better off with the capsulotomy. If we look at depression, and depression has been a great, if you like, disappointment for functional neurosurgeons because the subgenual cingulate was touted as a fantastic target and the initial open label trials gave us some positive results. But then recently, or a few years ago, in Lancet Psychiatry, we had publication of the largest trial of deep brain stimulation of the subgenual cingulate for depression. And what was found was that there was an improvement in the MADRS scores and the depression scores, but the improvement was the same whether you were a control, in other words, you had the DBS put in but never activated, or whether you had stimulation. So what we've recently been doing together with my MSc student, Pauline Munchenberg, is that we've looked at the literature and we've gone through the literature to look at the results of capsulotomy or cingulotomy, ablative stereotactic surgery for depression. And what we found is that if you've had DBS, right, your pre-op baseline was 33.8 in terms of MADRS, the higher numbers are worse, and your 12-month post-op, if you've had DBS, was 23.2. If you had a capsulotomy, then your baseline pre-MADRS was 39.3, but your 12-month post-op was 20. In other words, the capsulotomy patients are more severe, but they end up slightly better. And the absolute change in terms of the improvement in the MADRS scores is almost double. If we look at the number of responders, the percentage responders, now many of the capsulotomy studies use the BDI score instead of the MADRS score. And if you look at remission rates, a 50% reduction in either MADRS or BDI is considered remission. So the numbers of patients that have been published with MADRS scores after capsulotomy or cingulotomy is quite small, 22. But the number of patients published with BDI scores is actually higher than the number of patients in the DBS trial. And what we found is that it's almost double. It's significantly higher. So you're much more likely to be in remission a year after surgery if you've had stereotactic ablation than if you've had DBS. The other interesting thing is that this response is likely to be a sham response. So if we assume that the sham response after stereotactic lesioning for depression is the same amount, and probably it's the same, maybe even less, because with DBS you've got a lot of placebo effect because you're coming back for the stimulation adjustments, etc., etc. But let's assume they're the same. Then here we have a 10-point difference, which may be due to placebo, but we have a 10-point difference, which may be due to organic improvement, a mechanism of disease. So I think we should not call time on stereotactic ablation for lesioning because there's significant evidence, or suggestion rather, that actually it may be better than DBS, and it's cheaper and it's easier to look after these patients. One of the other diseases that has been mentioned is anorexia nervosa, and there's a lot of interest in terms of DBS versus ablation. There's a brilliant study from China with a very large number of patients. I think it's 75 patients showing significant improvement in BMI and in many other ways of looking at improvement in anorexia. But what bothers me is that a very good colleague of mine, Tipu Aziz, published a paper saying that he's going to examine deep brain stimulation in anorexia, and I think that's brilliant. But then a couple of years later, he said that we have a moral obligation to prioritize research into deep brain stimulation and not lesioning procedures for patients with anorexia. And I found this to be rather counterintuitive, because if you have anorexia, do you really want to have a metal box under your chest when you have body dysmorphic condition? Do you really want to have wires implanted when your immune system may be less and you may be more susceptible to infection? Do you really want to have deep brain stimulation that requires a general anesthetic when you could have a stereotactic ablation that requires a local anesthetic, when we know that these patients often have metabolic problems? And finally, the most important thing is, shouldn't we be asking the patients? There are some patients who may want DBS. There are some patients who may want lesioning. And I think it's very important that we do research on both methodologies. So I also specialize in patients with facial pain. It's fantastic that I can give them a radiofrequency ablation of the Gasterian ganglion. I can do a microvascular decompression. If you've got trigeminal autonomic cephalalgia, I can do DBS or sphenopalatine ganglion stimulation. To have an armamentarium of therapies that can help our patients is positive. And this isn't necessarily a competition, and we should recognize the pros and the cons of each treatment and adapt our selection and include the patient in our selection for the various therapies and the various research programs. We do have a massively large ethical problem or ethical challenge because of the history of psychosurgery. And here you can see a patient who's had a temporal lobectomy and hippocampectomy for epilepsy, but no one's up in arms that you can't do a lobectomy for epilepsy. That's accepted practice. But then when we do a capsulotomy, right, whether it's RF or gamma knife or focused ultrasound, psychiatrists say, oh no, we can't lesion the brain, we shouldn't do that. And this is a little bit of a, I think almost a denigration of mental health patients. We are actually psychiatrists who are supposed to push for the rights of mental health patients aren't referring patients because they don't see this as an organic disease. And I think this is a problem that we have to face together with our psychiatric colleagues. And I also think it's important that we don't forget ablation for the simple reason that in many countries, these patients can't afford DBS. These countries can't afford DBS. And if ablation is just as good, or maybe even almost as good, certainly if it's better, we shouldn't be discounting it. So let's ask ourselves that important question again. DBS versus ablation in mental disorders. Why is DBS more attractive than stereotactic ablation today when treating mental health disorders? And I would say that the reason is fashion, because all we do is DBS these days. There are very few surgeons around the world who know how to do a stereotactic lesion properly, and I'm hoping that many of those are on the call today. But this is a very important technique that we should know about, and we should use more often when appropriate. And there is no risk of having gait problems and balance problems and speech problems when you're doing a bilateral cingulotomy or when you're doing a bilateral capsulotomy. The risks are actually very low, and therefore we should not forget about lesioning for these patients. So as I said before, well, there's a huge interest in mental disorders, in neurosurgery for mental disorders. And I'm not sure how many people, I think I can see 121 participants for this session, which is an amazing number when you consider that if you count the number of psychiatrists who have published on neurosurgery for psychiatric disorders, you can fit them all onto the fingers of two hands, right? So there are many more neurosurgeons who are interested in neurosurgery for psychiatric disorders on this telephone call, on this video conference, than there are globally psychiatrists who are interested in this condition. And that we need to change that. There are challenges. Psychiatric disorders are more heterogeneous than movement disorders. Patients often have multiple comorbidities, so you can have OCD with a movement disorder, with a personality disorder, and teasing these apart can be a challenge. This is true of Parkinson's disease, of course, but we need to understand how those comorbidities affect the potential improvement in these patients. There's also numerous different brain targets that we can choose from, and therefore it's difficult with a small number of patients to have large studies on a specific target that's going to give us good answers, good scientific answers. And there's lots of techniques. So again, getting large numbers of patients with a single target and a single technique to try and understand its efficacy and downsides is going to be tough. And there are few patients being referred, but as we can see from this call, a huge number of centers are interested. So concentrating those patients into a trial in a few centers is going to be tough. The outcome measures are difficult to interpret. A Y-box improvement doesn't always improve your global assessment of function. And sometimes a small improvement in Y-box can have a massive increase in the global assessment of function. So again, these are a number of challenges, but we should be up to it, and we must be up to it because the burden of disease is very high. So in summary, there is growing evidence that stereotactic neurosurgery, whether it's ablation or DBS, can significantly help selected refractory patients, certainly with Tourette, definitely with OCD. Depression, the jury is still out, but I think it's exciting, especially ablation and capsulotomy and cingulotomy. Significant improvement in symptoms can be accompanied by massive improvement in quality of life. I think we have to understand that DBS for mental disorders, and I say this from experience of small numbers of patients, but it's a very big challenge. It requires lifelong surgical surveillance, and these patients are much more demanding than movement disorder patients in the long term. We should definitely not discount stereotactic ablation because the results are not necessarily inferior to DBS, and it may have some advantages. But I don't think we should discount DBS. And really what we should be doing is asking our patients, because some patients may prefer the idea of DBS, may prefer the idea of lesioning, and they may have very important personal reasons to prefer one over the other. And therefore, I think as a community, we should not denigrate one or the other. We should work together to gather the data in a very ethically sound fashion so that we don't make the mistakes that were made 100 years ago or 80 years ago, because we can help these patients and we shouldn't miss the opportunity to do so. So finally, I'd just like to acknowledge the huge team of people that I work with. So at the top slide here, you can see lots of members of the OCD network throughout the UK, with my mentor, Marwan Haris, who was instrumental to inspiring me in this part of neurosurgery, and the whole team of the unit of functional neurosurgery that I work with, and they're a lot of fun to work with them, and of course the various funders that have funded our work throughout the years. So with that, I'd like to say thank you very much, and I'll stop sharing my screen now. And if there are any comments from the panelists, it'd be wonderful to take them. Thank you. Paolo, I can see your mouth moving, but I can't hear you. I think you're on mute.
Okay, thank you very much, Professor Zrinzo. It's exciting, the presentation. Thank you very much. We have many questions. I would like to thank you all audience, but the question will be answered after the comments of our moderators. We would like now to take a poll, very quick. 20 seconds to answer one very interesting poll. Okay. Let's go, everybody. The audience, the panelists. Yeah, we need some music, huh? I believe that rock and roll or not one opera. Huh? Okay. Okay, everybody answer. Very good. Okay, very good. 5 seconds. Thank you, everybody. Thank you, everybody. And now, the second pool. The second pool is beginning now. Is a question about your knowledge, your expertise, your curiosity, and neurosurgery to mental health. We would like to know who is our audience. If someone or everybody believe in the same things, I hope not. Controversy is the most important thing in the evolution. We need to be critical. Okay, 5 seconds. Okay. Thank you very much. Thank you very much, everybody. And the last one. Now is the last one. It's easiest. 20. Come on, everybody. We know who is our audience. It's important, your opinion. It's very important we know about you. The answers will be in the end. Who is your colleague? Who is the another person we are looking for us? Well, 5 seconds. Okay, now we finish. Thank you very much. Thank you very much, everybody. It was very, very good participation. I would like to thank the audience again. Now, I would like to call them moderators. Professor Osvaldo Vilela, could you talk to us? Welcome, Professor. Take your time.
Thank you very much, Paulo. Thanks for the magnificent presentation, Ludvic. As you know, I defend surgical lesioning for the treatment of a variety of disorders, including psychiatric disorders. And in my point of view, in general, I would say that for neurodegenerative disease, I would certainly prefer deep brain stimulation due to the evolving characteristic of the disease. But for diseases that do not have this kind of evolving paradigm, I think that lesioning can be preferable many times. You know, when you perform ablative surgery, the treatment of our involvement with the treatment usually finishes with the surgery. And when it's the DBS, our involvement starts with the surgical procedure in general. And, you know, the comparisons between surgical lesioning or DBS for OCD and for depression, I have no doubt that as it's exactly as you have said, they're pretty similar. The results are almost equal, even if not better sometimes with lesioning. Regarding one of the disorders we have talked about, specifically Tourette's syndrome, I would say that in the single disorder, I would prefer DBS instead of lesioning. You know, I have made a revision or a review of the patients in the literature who have performed, who have undergone a lesion surgery for Tourette's. And the neurological morbidity is pretty high, around 28%. I'm not talking about abscesses, weight gain, nothing like that. Just neurological morbidity is pretty high. Now for Tourette's syndrome, particularly, I prefer DBS instead of lesioning. One thing that I would like to ask you, Ludvic, is why do you think that when you perform bilateral lesioning for movement disorders, the risk of neurological morbidity is quite significant, while when we perform them for psychiatric disorders, it's not like that. So I'd like to hear you in this regard.
So, I mean, the ultimate question is I don't know, but the conjecture is that when we're operating on lower order functions like movement disorders, the brain is actually quite lateralized, and there's a final common pathway to get to the ultimate movement. I think when we're looking at higher order functions, we often find that it takes time for the symptoms to improve. And therefore, when we do the intervention, what's actually happening is that there's the intervention, but then probably a degree of plasticity on top of that. And I think because there's a lot more bilateral connections between the two sides and higher order functions, I think the brain is much more resilient to bilateral lesions when we're doing lesions in higher order function brain. That's my main understanding of it. The other thing is that we know that there are lots of direct connections between motor areas of the basal ganglia and the brainstem areas that control gait and balance, whereas there aren't so many direct connections from the frontal lobes and from the higher cognitive areas within the basal ganglia to the brainstem. So I suspect that we're much more likely to affect the brainstem control of gait and balance when we're lesioning motoric areas of the basal ganglia corticothalamic pathway. And that's exactly why I think you're absolutely correct that DBS is probably preferable in Tourette syndrome, because I see Tourette as really almost a neuropsychiatric / movement disorder. And then some patients with Tourette's have quite a lot of neuropsychiatric comorbidities such as OCD and depression, but many patients with Tourette have motor phenomenon with very few OCD or other higher function pathophysiology. And I see Tourette's as straddling that, and I suspect that when we intervene in motoric areas of the brain that can help with Tourette's, the risk of problems goes up, as you just said.
Paulo, do I have time for just one other comment?
Of course.
You know, for depression specifically, Ludvic, We do not perform capsulotomy. I have no experience at all with capsulotomy for depression. And I do not perform cingulotomy alone as well, since I think that the results with cingulotomy alone are not as good as when you associate with subcaudate tractotomy. In our subcaudate tractotomy target, we have moved our target to a little bit anterior than the usual one. So when we perform that, we take together the subgenial cingulum. And doing that, we have observed that the good results are much better than we perform the old way subcaudate tractotomy associated with anterior cingulotomy. The other thing is, just to finalize, the only single operation that I don't feel confident to perform bilaterally in patients with psychiatric disorders are those with refractory aggressiveness. For example, specifically for the hypothalamic target, I have performed some in the past, but when we did that, the patients took so long to wake up after surgery. I had one patient that took 1 month to wake up after surgery after bilateral post-remedial hypothalamotomy. And then I stopped doing that. But that's the only case that I do not perform a single time bilateral surgery in psychiatric disorders. That's it about me. Thank you very much.
That's very interesting. I mean, I have very little experience of post-remedial hypothalamotomy for aggression. And the few cases that I've been involved with have been very severe patients with self-mutilation and self-harm. And it is quite, well, from the literature, it's quite common that patients are obtunded for a while after bilateral lesions. But in the patients that I've been involved with, we made fairly small lesions, and that wasn't a big problem. Within a week, it had resolved. But I take your point. The other thing is, this is really on the fringe. I think the number of publications supporting the use for post-remedial hypothalamotomy for aggression is fairly small and fairly limited. Nevertheless, in these very severe patients who have refracted to absolutely everything and who are damaging themselves and there's no other therapy, it's something to bear in mind. And DBS is not an option in these patients. It's just not. That they would break the DBS. They get infected. I can't even begin to think of a patient in that condition having DBS.
Thank you very much, Professor Osvaldo. Very important comments and questions. I would like to ask Professor Godinho now. Professor Godinho, could you hear me?
Hi, Paulo. Are you hearing me?
Yes, now, please.
Okay. Thank you. Thank you, Paulo, for inviting me. Thank you, Ludvic, for this brilliant talk, very nice talk. I have a lot of questions, but I will focus on some because our time is very, very short. We are performing surgery for OCD, DBS for OCD. And the anatomical area we target, I mean the ventral stratum, ventral capsule is quite large. So we have some difficulties to know exactly what specific area of this large area would be better target. Do you believe that some functional methods such as tractography, for example, could help us to better target this region, and how? Because it is very sensible to a lot of parameters. So you could draw fibers as you wish. So it's very challenging, this method as well.
Yeah. Okay, so first thing to say is that it's really difficult to answer these questions because let's go backtrack a little bit. We've been doing STN DBS for decades on hundreds of thousands of patients. And it took a few thousands of patients before we understood where the sweet spot was in the STN, when we were talking about dorsolateral. And until a few years ago, people still didn't understand what dorsolateral means. Some people were saying it was anterior and superior and lateral, and some people were saying it's posterior and superior and lateral, which is what I think the evidence points towards. Posterior, superior, and lateral is the sweet spot, whether it's the STN or just above the STN. So, and the reason for this is that we need large volumes of patients to look at outcome versus lesion location before we can make any firm conclusions. And because of what I've just said in terms of the variability of patients with OCD, maybe we're seeing the variability because of the variability in the pathology rather than the variability in the lesion. So I think it's very difficult to draw conclusions of lesion versus improvement based on the available data because it's so small. Nevertheless, it's a really important question, and some people have tried to answer it. And Clement Hamani and others, as well as the Dutch group, have tried to look at this. And to the best of my knowledge, for the capsule, especially in OCD, what you should be aiming for is as ventral as possible, as low down as possible, and medially as possible as well. And that seems to be the sweet spot on the data that we have available. Another theory is that really what we should be looking at is the medial forebrain bundle and its projection into the internal capsule, the ventral part of the internal capsule. Again, I have problems with this because the medial forebrain bundle is actually a fairly small structure, and a lot of the papers that are published are looking at deterministic tractography, which is not the right way to look at small bundle fibers. Deterministic tractography you can use for massive bundle fibers like the internal capsule and like the corpus callosum, but for smaller fibers it really falls short. And we see that it falls short because whenever you come to crossing fibers or kissing fibers, the anatomy doesn't look like the anatomy that we know exists. And therefore, we know that this is a statistical tool, and the statistics falls apart. We can do a little bit better with connectivity, with probabilistic connectivity. But again, I see these tools as really good tools when you're looking at group data, because when you look at group data, variability evens itself out. But for using connectivity to help us target an individual patients, my faith in the technique, if you like, breaks down, because I'm not a believer, I'm a scientist. So I think at the moment what we should be doing is really recording the baseline data of these patients in extreme detail, recording the outcome of these patients in extreme detail because it's not always available in published papers, and recording the lesion, the volume and the position in great detail. And once we have enough data like that, then we can start to talk about, well, okay, these are predictive measures that we can help patients based on their baseline data or based on their lesion placement. But before we have that data, I think it's all a little bit castles in the sky.
Okay.
Okay, thank you. Thank you very much. Just, Paulo, may I have just one question?
Please.
Ludwig, do you have in Great Britain a randomized blind study comparing lesions versus DBS for movement disorders or mental illness or anything else? And if you don't have, why?
Okay, so first of all, there are studies of lesions versus DBS and movement disorders, and the Dutch performed this with thalamic surgery for tremor, and the results were very interesting. And they said that DBS was better, but actually, when you look at the data, and especially the long-term data, I'm not so sure. Definitely, when you're doing bilateral surgery, I think the evidence was fairly clear. But for unilateral surgery, again, I'm not so sure. And I've had patients who have had DBS on one side and lesion on the other, and they said, well, why didn't you do a lesion on the other side? This is so much, the lesion side is so much better. I wish you did the lesion on the other side as well. And there are some people like Takataira in Japan and others who are actually now biting the bullet and doing bilateral lesions. And the theory behind this is that the bilateral lesion scare, if you like, which is very valid, I think, for now, was from an era when we didn't have good imaging. And maybe we were encroaching on the internal capsule when we were making those lesions. And now that we have good imaging, maybe we can get away with staged bilateral lesions. But again, it's angels fear to tread where fools rush in, right? So I think we've just got to be a little bit cautious about that. Now, your question about whether we should be doing a randomized control study for DBS versus lesions is an excellent one, and I've contemplated it many, many times. But one of the things that we do before we do a randomized control trial is we approach the patient groups. So one pathology that I'm very interested in is anorexia, because anorexia has a massively high mortality. And when I went to speak to the patients, it was very, very clear to me that the patients who would consider surgery had a very strong opinion that they either wanted DBS or they wanted a lesion. But they did not want to be told, I'm going to randomize you to either a DBS or a lesion. They felt that that was too much control to give up to a paper envelope, and that they were going to be condemned to a battery if they saw it that way, or they were going to be condemned to a burn in the brain if they saw it that way, because they wanted a battery, or they didn't want a battery. It was the bottom line. So I think it's the wrong question to ask. And I think that's why we're not doing trials like that anymore, because the right question to ask is, what does the patient prefer? And how can we gather more data so that we can inform the patient better of the pros and cons of each therapy, and that the patient can choose? I think it's a false question to ask, do you want this or that? I think the question is, what's the evidence for this? What's the evidence for that? What's the pros and cons for this? What's the pros and cons for that? And then you can choose. And I think that's a much better approach to what we're doing, to just saying it's one or the other.
Brilliant. Perfect. Thank you. Thank you very much. Now I would like to begin with the question come from audience. Professor Ludvic Zrinzo could be the first question. Informed consent requires the patient to have adequate knowledge of the surgery, complication, and possible outcomes, all without undue pressure from relative, cardiologists, or even doctors. In your opinion, how can informed consent help or hinder the indication of neurosurgery for mental disorder?
Okay, well, I think this is a really important question, because it's all about the ethics of surgery, and informed consent is at the basis of what we do. So the bottom line is, informed consent will never hinder the indication of neurosurgery for mental disorders. It can't. Informed consent is essential for every sort of surgery, especially surgery for mental disorders. I think it's really, so here in the UK, we have mental health legislation, and every patient that's going to undergo surgery for a mental health problem has to be referred, it has to be seen by a psychiatrist, his psychiatrist, and an independent psychiatrist, and a board appointed by what is called the CQC, the Central Quality Commission, and surgery has to be approved. Now, every patient that we've submitted for this has been approved from Queen Square. In other words, they're not there to stop the surgery, they're there to supervise the surgery. And I actually feel safer having gone that way, because I know that things can go wrong or things don't always improve. And it's really important for the family and the patient to be seen that we are doing this not for our justification, not for our career promotion, but really for the welfare of the patient. I think that's really, really important. The difficulty with informed consent is that truly we don't know, we don't have a really good answer as to what the benefits and the risks are. And we inform that by gathering data, by doing our own data, because they don't care what the risks are from the publications, they care what the risks are in my practice. So we really need to build up data from our own practices so we can inform these patients properly. So again, the short answer to that question is informed consent is absolutely important, and therefore going through a central organization, either a legal method going through the country's legislation, or from your own institution getting an independent source, is important to make sure that there isn't undue pressure from relatives, caregivers, and doctors, and that the surgery is being done with the patient's best interest in mind.
Thank you. Another question is, can a history of cerebrovascular disease, of preexisting epilepsy rule out neurosurgery for mental disorder?
So again, I think the problem is when you've got cerebrovascular disease, especially if it's widespread disease, it increases the risks of surgery. It increases the chances that the underlying circuits involved in the pathophysiology are no longer, you can no longer modulate them. So this is like a patient with severe atrophy in Parkinson's disease. And most importantly, the physiological reserve, if you like, is much less in patients who have these sort of issues. I think pre-existing epilepsy is not necessarily something that I would rule out neurosurgery for mental disorder, but I would be very cautious about suggesting neurosurgery for patients with cerebrovascular disease.
Okay, thank you again. The next question. We are still looking for some objective measure of the outcome, a biomarker for patient operated on with treatment-resistant depression and OCD. PET scan, fMRI, prefrontal cortex morphometry, electrophysiology, theta wave. Which do you think is the more promising and why?
Okay, so again, let's go back to what we know. If we go back to Parkinson's disease, do we use FDG PET to look at to predict outcome? Do we use fMRI to predict outcome? Do we look at prefrontal cortex morphometry or electrophysiology or theta waves? No, we don't. We look at the DOPA challenge. We look at the age of the patient. We look at the comorbidities of the patient. We look at the psychology, the cognitive profile of the patient. We are hunting for biomarkers when we still don't know the clinical features that are likely to improve outcome, whether it's OCD or depression, et cetera, et cetera. And the reason that we're looking for these biomarkers is the number of patients that we operate on is so small that at the moment, all we can say is there's an X% chance if you have OCD or a X% chance if you have depression, if you have this therapy to help you. But the numbers are under 100. I showed you the meta-analysis of stereotactic ablation for depression. The numbers of patients published with good data before and 1 year after surgery, after stereotactic ablation, is 79. 79. And how many thousands of patients have had stereotactic ablation that potentially around the world, but only 79 have been published. So until we start gathering this data, we will not know what the objective measures are for predicting outcome, but I can predict from now that those measures are going to be clinical measures rather than physiological measures, because that's what we've had from pre-existing illnesses like Parkinson's disease and dystonia.
Wow, excellent. The next question. Thank you very much. The next question is, the enthusiasm led to large randomized clinical trials, which ended shortly after interim analysis determined a low probability of a positive result. In your opinion, what was the main problem? Study design or the region for DBS implantation?
Okay, so they're clearly talking about depression here, because if we look at OCD, large or not so large randomized clinical trials showed that there was an extremely significant and large benefit with stimulation over sham stimulation. So I think the problem is when you have a randomized controlled trial that needs large numbers to show significant improvement, then this is not a suitable surgical therapy. Because if you're doing surgery, you have to have big effect sizes. If you have to treat 100, in hypertension, it's acceptable to treat 80 patients with an antihypertensive drug to prevent one heart attack or prevent one stroke. But in functional neurosurgery, it's not acceptable to treat 80 patients to get one patient better. We need to have at least 50% of patients doing significantly better. And I think in the randomized controlled trial of DBS for subgenual cingulate stimulation, my interpretation is that this was mostly due to a placebo response. And I suspect that the subgenual cingulate is not the right target for depression. And I think that there is some evidence, like I've said, already out there in the literature from the meta-analysis that we're conducting, that lesioning the cingulate or the caps or the ventral capsule may be twice as good, and definitely a lot less laborious, and definitely a lot less expensive. So, you know, I think we can continue looking at tractography and trying to isolate one tract from the other. But the truth is, there are hundreds of thousands of patients out there with severe refractory depression. DBS is never going to treat the vast majority of them. If we should be doing research, I actually think we should be looking at lesioning, because it's a quick, simple procedure, cheap, reproducible. I think we're barking up the wrong tree.
Thank you again. The next question. Ventral anterior limb of the internal capsule is the best DBS target for treatment-resistant depression?
Very good question. So again, the evidence in favor of capsular DBS for depression is not very strong. I think if you're going to do ventral capsular DBS for depression, you want to do bilaterally. You've got to, again, if you're doing a study, you've got to measure the outcome before and after. Trials to date have not been successful in showing improved outcome. And I say it again, why aren't you lesioning the ventral capsule? We have really good data that lesioning the ventral capsule is great, or not great, but is pretty good at helping depression, in the sense that 60% of patients with a capsulotomy for depression improve. And if you're doing stereotactic ablation from the meta-analysis, you've got an almost 50% chance of being in remission, of responding within a year, and your chances of being in remission 2 or 3 years later is actually pretty good too. So again, it's not a perfect treatment, but we are talking about the worst of the worst patients being selected here. And I think if you've got a 1 in 2 or a 2 in 3 chance of improving after a cheap procedure that has no expensive hardware and doesn't require surgical follow-up, I would put more of my effort into doing studies on those therapies. But of course, no rich company is going to pay you to do that. So perhaps that's part of the problem.
Professor, how do you think about VNS for depression today and in the near future?
So I have no experience with VNS for depression, but I work very closely with Keith Matthews, who's a psychiatrist in Dundee. And they've looked very carefully at VNS for depression, and they've actually published on this already. And they were underwhelmed, to say the least. And they feel that a lot of the improvement after VNS for depression is probably placebo related. But I know that there's a volume of data out there, but the data is pretty poor. And the truth is, if you're going to do a procedure and you're going to do it for its placebo effect, well, VNS is not a bad therapy to do, because the risks of causing harm are pretty small. But I think, again, I would argue that in the right hands, a stereotactic ablation procedure is likely to be more effective, cheaper, and can be done very safely.
Okay. What do you consider the ideal target in OCD? DBS in the striatal region or STN?
Okay. So the first thing to say is the data is not available. So I can't just answer that. However, if you want an opinion, I think the evidence shows that STN DBS is extremely good for OCD, as is ventral capsule. The only head-to-head study that's been published is our own of 6 patients, so the number's really small, and the improvement in OCD was similar in both bodies of patients. The only difference is that mood improved more in the ventral capsule patients, and that's what the patients like. The patients like the fact that their OCD is better, but they like the fact that their depression and their mood is better even more. And the vast majority of patients who are still being stimulated, so the 5 patients who are still being stimulated in our study, our 5 out of 6 patients, is no longer being stimulated for other reasons. but they all have capsular stimulation. Not all of them have STN stimulation.
Okay. Can the significantly longer duration of OCD also make a significant difference between patients who responded to surgery and no responders?
So again, I don't know that the data is available to answer that question, but what I would say is that the problem with the duration of disease is that if you wait 20, I don't know, 10, 20 years before you treat severe OCD, well, life has run that person by. That person has lost the opportunity for an education. That person has lost the opportunity for a family. That person has lost the opportunity for employment. So even if the Y box improves, if you've left it 20 years before you've treated it, you've lost the life or a significant proportion of that life. So in terms of functional outcome, I think it behoves psychiatrists to really treat patients with OCD properly with SSRIs and CBT, and then if they fail, not to keep doing the same thing for decades and decades and referring the patient after 20 years, but if you have a good dose of 2 or 3 SSRIs, 1 or 2 inpatient cognitive behavior therapists, you're 3 years into severe disease and the patients know better, well, what are you waiting for? I mean, and part of what I see as the benefit of the service I provide, so we provide the national service for neurosurgery for OCD in the UK, but for every, I'd say, 10 patients who are referred, actually we find that 3 of them don't actually have OCD, they have other conditions and were poorly diagnosed. 6 of them probably have OCD, but haven't been treated properly. And when they're treated properly, they actually recover with SSRIs and CBT. And 1 of them, right, is truly refractory OCD and then is suitable for surgery. So one of the ways that I see neurosurgery as being positive for these patients is it focuses the minds of psychiatrists to give the very best therapy for these patients before they go on to surgery. So the short answer to your question is yes, duration is very important in terms of outcome for OCD, but not necessarily for Y-box scores, but definitely for improvements in quality of life.
Thank you. And Professor Zrinzo, in your experience, what is the minimum number of the weeks that you expect to start seeing improvement after ablation to Tourette?
Ablation for Tourette?
Yeah.
So I have no experience of ablation in Tourette. So I would defer to Dr. Villela, who seems to have some experience of ablation in Tourette. I don't know the answer to that.
Professor Villela, do you like to answer? Could you answer, please?
No. Well, actually, I have performed just 2 surgical ablative procedures for patients with Tourette syndrome. And when we did that, the response was immediate. So it didn't take long. But taking that lead, Paulo, Ludvic, I would like to ask one other question. Why do you feel that after lesioning for psychiatric disorders, the responses are postponed for months or even years?
So like I mentioned before, I think with higher order functions, when we're interfering with the circuitry, we're relying on plasticity of circuits for the therapeutic benefit. So for example, for tremor, right? Tremor is a lower order motor function. And when you interfere with that circuit, the tremor stops immediately. But dystonia, why do we have tone in our muscles? We have tone in our muscles because we're preparing for a movement. So tremor is an immediate movement, but dystonia is preparation for a movement. So it's a higher order motor function. And actually when we operate for dystonia, it can take a few days, if not weeks, sometimes months, to see the benefit, because I think we've got plasticity. I don't think there's actually physiological evidence that there is plasticity in those circuits that actually mirrors the clinical time course of the improvement. And I think that's just even more true for things like depression and for OCD and for higher order functions. Having said that, we often see small improvements early on, even after cingulotomy or capsulotomy. And I remember the very first cingulotomy that I was involved in, we were operating on a patient with severe depression, and we had just done the second cingulotomy, and the patient started crying on the table. And I was mortified. I said, oh my God, we're doing surgery for depression and the patient's crying. And I turned to the psychiatrist, and the psychiatrist was happy. And I said, why are you happy? He said, because this patient hasn't cried for years. And the fact that she can cry is a very positive sign, because she's actually registering an emotion that she wasn't able to register before. So sometimes you do see acute effects, but the positive acute effects can be delayed for a while.
Excellent, excellent. Let me do the last question, because our time is finished. In your experience, considering only the rate of serious adverse effects like suicide, death, hemorrhage, what is the difference between lesion techniques and DBS?
Okay, so I think the question is a little bit vague, because I don't know whether it's talking about depression or OCD, because it mentions anteromedial STN. Let's start with depression. Let's say we're talking about depression. So we just, and I know this just because we finished a meta-analysis, or in the process of doing a meta-analysis of stereotactic ablation for depression. And all of the papers that mention suicide say that suicidal thoughts were diminished after capsulotomy or cingulotomy. The one important comment I'll make is that some papers didn't even talk about suicide or suicidal ideation. And to write a paper on depression without mentioning suicide, I think is really quite tough. And this is a comment that we have on our meta-analysis, that you need to have a minimum data set when you're reporting surgery for depression, and suicide should be on there, or suicidal ideation should be on there. In terms of OCD, the OCD rate and the suicide rate in OCD is usually fairly low. Patients with OCD don't often commit suicide, but I'm aware of a few patients published in publications who have had performed suicide or tried suicide after STN DBS for OCD. Again, it's very difficult to comment because the number of patients is very small. And the worry is that with STN DBS, you remove inhibition, as we've seen in Parkinson's disease. And I think that that's why this question is being asked. Again, I don't have enough data to answer this question properly. But my feeling is that the rate of suicide after capsulotomy, the reported rate, is actually very low, whether it's for OCD and there's an improvement or a reported improvement where it's been bothered to be reported after capsulotomy for depression. I think suicide is always a tragedy, and I think the small number of reports should be a cause for concern. However, I think we just don't have enough data to reach a conclusion one way or the other.
Thank you very much. I would like to, in our last 5 minutes, I would like to comments. I would like to comments about the panelists, about our pool. I would like to hear comments about Professor Zrinzo, Professor Osvaldo, and Professor Godinho about the results.
If I should go first, I mean, I'm looking at the results of the poll. I think the vast majority of people have said that all of them must be severely altered, and I must agree that that's what I selected. I think there is no one thing that's important. We have to consider it's a very holistic approach, and I'm glad to see that the majority of people went for all of these factors as being important in the decision making.
Professor Vilela, Professor Godinho. Any comments?
I have no further comments. I completely agree. That's the best alternative, of course.
Professor Godinho?
That's my alternative too. No comment about it.
Okay, the second two, I would like to hear some comments.
One of the other panelists should go first this time.
Otherwise, they will agree, everybody.
Okay. This last one.
This is an interesting one. I might comment on this one then, Paolo.
Yeah.
So for me, I think the greatest challenge is convincing psychiatrists to send us patients. I think that's the major thing. Finding the right indication, which is the winner, of course it's very important, whether it's stereotactic lesion or DBS. But the truth is we'll never find this unless we have the number of patients to answer these questions. And the only reason that our specialty exists at the moment, or that our specialty has had this renaissance, is that neurologists turned to us for help with their Parkinson's patients and with their tremor patients. And if they don't refer us these patients, then our discipline dies. So we have to get psychiatrists, we have to teach a new generation of psychiatrists that actually the mind has something to do with the brain. And actually in some patients, we need drug therapy, we need cognitive behavioral therapy. But sometimes it actually, if that fails, we have to think of surgery and we have to design trials of surgery to gather the data to make the results better by patient selection, target, and technique.
Professor Villela?
Yeah, I agree. The greatest limitation is really to involve the psychiatrists in our teams, so they start really referring patients for surgery. It's pretty rare, very, very rare. The next important thing is really to define the best candidates. You know, depression is a very widespread disorder. There are many things when we talk about depression. Are the patients mainly anhedonic, or what kind of patient is this? So you can answer the question, which are the best candidates. The same thing happens with OCD. There are very many kinds of different obsessions and compulsions, and some seem to respond much better than the others. So patient selection is really too important to me as well. But the first one, I agree with Ludvic, is the referral from the psychiatrists.
Thank you. Professor Godinho?
I think all alternatives are great challenges for the evolution of neurosurgery, not only in major depressive disorder, but also in LCD. But in my opinion, the fourth alternative is the biggest one, the most important. In the last 2 years, we had 2 patients approved by the Brazilian Medical Committee for DBS surgery for OCD. In the past 2 years, 2 patients. So it's very, very complicated to have patients, very complicated to treat these patients. So I think the fourth alternative is the biggest challenge.
Thank you very much. We've had an excellent webinar today. I would like to call our president, Dr. Antonio Almeida, to finish our webinar. Thank you very much, everyone. Professor Antonio, please. Oh, Zrinzo, you'd like to talk again?
To ask, I have a number of question and answers over there, which I'm very happy to answer. Can I keep doing that after the webinar talk finishes?
Absolutely. We will send for you, and you absolutely you back the answer for us.
Perfect.
Antonio?
Great. It was a great talk. It's really a very interesting topic with a very clear explanation of the situation of the psychiatric surgery today. And I would like to thank everybody. It was a great time we spent together. Okay, next week we don't have a webinar because of the functional week of the Society of the Brazilian Society of Neurosurgery, but in 15 days we'll be back again. So thank you all. Bye.
See you. Thank you very much.
See you guys.
Thank you for the invitation. It was an absolute pleasure. Thank you.
Me too. Thank you, everybody.
I'll hang in here typing the answers to the questions.
All time. There are many.
Yeah, they keep coming.
And actually, after all this, after this period, we'll probably write down all these answers and questions and to make it available for all the audience. I think it's very interesting.
Absolutely.
Okay.
Bye-bye, everybody.
Bye-bye.
Bye, everybody. Thank you.